guys know Terri Meier? Woo! Everyone. So I'm excited to introduce her today to go through the No Surprise Bill Act. When we initially started the planning for this, she was going to take on be on the panel, and then we determined that through her knowledge and her background and everything that she's been researching, that she knows a lot more than just being on the panel. So we've asked her to do an overview of the No Surprise Bill Act in comparison to the state of California, which is great because she's basically outlined in clarity the significant differences for all of you. So with that, she's the system director at UCSD. If I could get a big round of applause for Terri.
So this is the one I'm going to hold. Okay. Okay.
Yes, we're done with that.
Okay. All right. Well, thank you so much for allowing me to come and speak with you today. I know Justin said, oh, we've got experts, but I'm no expert. And if any of you were on the CMS call yesterday, they're not experts either in this because they virtually could answer not one question that people were asking them. So how I got here was I was a revenue cycle director at Stanford. I got recruited down to San Diego to build their single billing office. And that was like in early 2016, I said, God, the only thing I was afraid of is taking that little, SBO job that I would lose my, director revenue cycle stuff. And sure enough, here comes Surprise Bill. And I wasn't in that space, and I saw I'm behind. So my organization asked me to kind of do some research on it. And when I was doing the research, I went, oh, well, maybe it's something that I could share with others. So that is why I am here today to speak with you guys. And you can go to the next slide. So the presentation is titled AB 72, but really this is part of the whole overarching price transparency legislation that we're all on this journey with where we are today. So January 2020, we had to post our charge masters, and then in 21 they said, oh, not only post your charge masters, but tell us all your rates that you have with all your payers. And the hospitals went, no. And I think there's still some of them out there that are saying no. And then they wanted us to do shoppable services, and that was great. I mean, that we could probably get behind. So now we're in January of 2022, and we've got no surprise billing. Next slides. But in doing some research, there are lots of states in the United States that have some level of No Surprise Act. California happens to be one that has a pretty substantial No Surprise Billing Act. So I think we're very fortunate to that extent. So what I decided to do was kind of start there. So we already have something going on. What's the difference between what we got going on and what the federal government is telling us you're going to have going on, right? So California has existing law that prevents and protects many patients from surprise medical bills, as well as precedent for previous California Supreme Court decision, which that is in regards to emergency, because AB 72 is just for non-emergency. So 2016, California passed AB 72 to prevent surprise medical billing when a patient sees an out-of-network physician in an in-network hospital. So that kind of went into effect July 1st of 2017, our version of the No Surprise Act. Okay, Justin, are you falling down? Yeah. We're supposed to be a team here. Okay. So for physicians, AB 72, the patient is only responsible for their in-network cost sharing when the out-of-network physician sees the patient in an in-network facility. And California also has a benchmark rate of 125% of Medicare, or the average contracted rate for that service, for that health plan in that region. So whichever one is greater. Providers or insurers we can appeal, and through an independent dispute resolution. And AB 72 applies to Californians with coverage regulated by the Department of Managed Care and the Department of Insurance. So the gap between AB 72 and the federal is the AB 72 does not cover the self-funded insurance plans that were under the Department of Labor, or those, we call them ERISA plans, I think, is that our acronym for that? Terri, you got to keep me honest on this. Okay. So that's the gap. But now with the federal, that gap's, it's obviously going to get closed. And then for emergency room bills, which wasn't in AB 72, there was a Supreme Court decision in 2009. It was Prospect Medical Group Incorporated versus Northridge Emergency Medical Group. The court unanimously ruled that the non-contracting emergency room doctors and hospitals cannot send the balance of a bill to consumers with Department of Managed Care regulated insurance. So supporting the kind of provisions of AB 72 in the emergency room realm. And then there's an Assembly Bill 1611, I think was from that was last amended June 27th, that kind of put in stone that we can't bill patients those out-of-network rates in emergency room across the board. So again, the gap is those ERISA plans, because they were not part of the Department of Managed Care or the Department of Insurance. So that's the gap. Then air ambulance, we don't, at UCSD, we don't do air ambulance, so be honest, I didn't spend a lot of time on this. So just the facts, and that's all I'm going to give you is the facts, is AB 651 passed in 2019 that protects Californians from being surprise billed for air ambulance. But AB 651 does not set a payment standard, and the gap also is it did not cover ground ambulance. Next slide. I was giving you an IQ, but I just okay. Then for notice for consent and balance to balance bills, so that's that kind of the same notice and consent concept as in the federal rule. Again, it has to be obtained by the out-of-network provider. The document has to be separate from all the other documents. It has to be written in the consumer's language. I'm trying to just do the highlights here. Consent tells the consumers that in-network care provider is available for a lower cost. Consent and estimate must be translated into the language spoken by the consumers. And I didn't know this, but there's actually a website out there by state with the federal government that tells you in your state what your 15 languages are. But so that was a little interesting tidbit, because I would have had no idea what they were. And then let's see, consent must inform consumers that out-of-network costs will not count towards their annual maximum. And if an out-of-network doctor fails to obtain the proper consent, obviously the consumer just has to pay the in-network cost share. And California also has an independent resolution process, similar to the federal RDR to a certain extent. And it's through the Department of Managed Care. I've got some screenshots in a couple of next slides. And the Department of insurance, because depending on what type of insurance it is, you have to know you have to go to this website to do my complaint, or I have to go to this website and do my complaint. It provides, you can do bundled claims. It has all the attributes that the federal one has. Either party has appeals. The decision, all relevant information may be considered when determining the appropriate reimbursement, including payments sought by the out-of-network doctor. Interesting piece, though, in California, I think, after the IDR, we have the ability to litigate, right? My lawyer friends know. Oh, but I think in the federal, they don't have that. They don't have that ability to litigate. And I know it was like kind of like Law 360. It's like this one website where there was an article written by, they're interested to see how that's going to kind of fall out, because I think we can litigate if we're not satisfied with the IDR process. So this is kind of what it looks like, and also on the Department of Managed Care, they have one for emergency services and one for non-emergency services. So, the more complicated they make it, I'm sure they're going to say, oh, they're not going to want to do that. So this is one for emergency, and it's also, there's certain criteria that you have to meet in order to qualify to submit a claim, as well as it costs money. Because that's how they pay for it. And so the next slide, this is kind of what it looks like for the non-emergency. Again, it references the AB 72, but same process. Next one. And that's just the one on the California Department of Insurance. I just wanted to give you a picture. So if you happen to go out there and say, oh, I saw that. Okay, next one. And then this was actually a article that was out there that they took a look back in 2019 at the effect of the AB 72 in July of, in 19, from July 1st of 2017. Of course, over the 2 years it did, from their perspective, because I think this was, from a patient advocacy group, oh, it's working. But from the physician perspective, there's many concerns about the unintended consequences that AB 72 had. Next slide. I think in so much so, well, I guess this was the ADR quarterly report. They have those out there on the website as well, where you can see each quarter how received through the IDR process. And as you can see, most of the volume is coming from anesthesiology. Next slide. And one of the interesting things there, kind of like when I read that and I saw that on the website, it was like, okay, so this was like a 22-page letter that the California Medical Association sent to CMS with their concerns about those unintended consequences. And then you saw that anesthesiology metric, right? Well, one of these is where they cite shortly after passage of AB 72, the Department of Managed Care state regulator found 0 anesthesiologists in Anthem's networks in 3 large California counties, one being San Diego. So again, I think, it was billed, for the patient, but I think there was unintended consequences for the patient because in the insurance company says, why do I want to contract with you, and I can just pay you this little bit amount under AB 72, and we can just call it a day. But so this 22-page letter was sent on September 7th. Detailing those unintended consequences, because if it happened to us and the federal rule is pretty much identically mirrors California's AB 72, it's most likely going to happen to everybody as well. So again, what does the federal No Surprise Act mean for Californians? Again, that now all Californians are going to be covered under the regulation and not just those under the Department of Managed Care or the Department of Insurance. But I won't go over all that because I mean, it's pretty much the same. It's a provider providing care in a non-contracting provider providing care in a contracting facility, and then emergency is always going to be part of this. So the gap, even under the federal, there's no surprise bill for people and that need to take an ambulance. So they were left out again. So next one, services always prohibited again are those emergency, and I think those participating providers that you know, that see those patients in that emergency setting, pathologist, radiologist, neonatology, again, anesthesia being one of the biggest ones. And then see certain, and this, I left this on here because I was not sure, but when I did this a couple of months ago for UCSD, I think there was a comment period still out, and I think this was under Part 1 of the No Surprise Act, and I was not sure if HHS added additional services under this category of always being prohibited from billing. So that I apologize, but I did not get that researched before I came here. But I hadn't heard of anything, so I'm just going to go with this. And then again, how are services paid in the federal? It first says if you have an all-payer model, then that's what you're going to go with. Of course, I think there's only 2 states in the United States that have that all-payer model. But then the next one, it says if you have a state-specified calculated amount, that's the one you use. And under AB 72, it is that next slide. 125% of Medicare, or the average contracted rate and all that other stuff. So how they determine the contract rate, this was very interesting because I couldn't find anything. Because that's everything, every place that I went to do my research, it would say data regarding average contract rates are not subject to Public Records Act because these rates are negotiated and the proprietary and confidential information. I would like to take that and put that on our CDM that we are being asked to post on our websites, because this we have to share, but they don't. So we are all not playing the same in the sandbox. So I would like to circle that and say, this is what you told me. And so there you go. The Department of Managed Care, this was a letter, an all-payer letter that the Department of Managed Care sent out to all of the payers regarding the notice to the enrollees. You know, again, under the federal, they're asking us to provide the patient with a disclosure. But I think this was kind of, back then in 17 was meant to be kind of like that disclosure. Next slide. So the decision in UCSD, it was, you know, gosh, are we going to balance bill or are we not going to balance bill? Because the requirements are different. At UC San Diego, because unbeknownst to them, they didn't know that AB 72 was enacted, and so they've never balance billed. So we're going with, we're not balance billing. So that's our decision. But what we did do, and we just got the data this morning, was, you know, gosh, we don't even know where we're at with this, right? Because we didn't know that that's what was going on. So what we did was we took all our non-contracted payers and ran the data against, 125% Medicare, and because they don't want to share what their rate is, right? We just used all of our contracted payers to see where what our reimbursement was for these non-contracted services, as in relationship to what we were getting for contracted services. And surprisingly enough, it was right on. So luckily we're getting paid right. But what the unknown is, the ERISA plans weren't part of that. So the direction is to those RISA plans that, the states, that's what the state is, their pay rate is, so you should pay that. So ongoing, what we don't know is, to make sure that they pay us right. But surprisingly, it looked like both on the hospital side for our emergency room services and our post-stabilization and our physician group, because I'm a single billing office, so it's both hospital and professional, and it looks like there isn't any big gaps there. And my department is customer service, so I would have assumed in the last 5 years that if there was a big deficit in what patients were being billed, they would have been calling to my office. Now I can tell you that we have gotten some, but for the most part, again, they were related to that anesthesiologist that didn't get paid right. So not to balance bill. If you're not balance billing, and and again, there's all kinds of things to consider, with that too. The patient financial experience, and oh gosh, because now you're cost shifting this on me, and all those conversations that are happening in relation to other things now are kind of part of the consideration, whether you're going to go down the route of always balance billing or not. So if you're going to balance bill, this is the decision to balance bill under the federal, and I can tell you it is, from my research, I won't go through all this, but it's just about exactly what is under AB 72 in California. Let's see, there was one thing that I was going to call out. Maybe it's on the next one. Because under AB 72, you have to do the estimate. It has to be a separate document. It has to be provided information about any change in the payment model, prior authorization. Let's see, states the providers that there's service with participating providers. So I think for the most part, it's the same. The one thing that I don't think was on the AB 72 is for the post-stabilization service, having to give the patient a list of participating providers. I think that was the one thing that I didn't see as apples to apples on there. But again, there are those times that you get a patient that wants your services, and that they're out of network. So now under the new regulation, you're going to have to go through this process for those. It also applies when a patient insists on seeing an out of network provider at a network facility. So again, that's that place of service 22 stuff. And what I read too also is, I know for us, when we get those patients that are out of net, we'll do a letter of agreement. I don't know, some of you guys, I don't know if you call it the same thing. They call it a one-time contract or something in the reg, but those are also part of this no surprise bill. So the patient's only liable for that in-network cost, even when you're doing those single service agreements with those insurance companies. Consent, so it's the same thing as the AB 72, given as the same time as the notice. It's got to be a separate document, must be completed by the patient under no duress. And, and the one thing that I noticed, I know CMS just sent out all of their supporting documentation. Was it like December 1st or something that they had for the good faith estimate and all of that stuff? Have you guys even read any of that stuff? Isn't it shocking? It's like if I was a patient, I would go, oh my God, wait till I get the bill because I know they're gonna bill me wrong. I mean, because it's kind of it sets it up. It just sets the wrong tone. I know for us at UCSD, I mean, those things you don't have to use their model. And we've chosen not to because it just, you got to take the temperature down a little bit because it just seems like it has gotten so contentious in some of the way that they're writing some of this stuff. So go on to the next one. Providers must notify plans. Okay, and Jerry, I've never balance billed. I don't know if you have either. I'm under the impression that you have, when you bill, it's probably paper, and then you've got to attach that consent that the patient signed. Yeah, I don't know, and I know there was some stuff in there that it said that's why the date on that consent is so important, because I think when you send it in, they're going to check with the date of the service. So then they can tick and tie that consent to make sure that they are paying that claim right. So, but I've never done it, so I don't know. So go ahead. This is just the federal IDR. I stuck this in there because I knew this presentation was going to be out there, so y'all can read it at your leisure. But it actually really does look like the same process as with the Department of Managed Care, even down to the baseball styles negotiation and stuff. So yeah, it's just, there's two of them, so you can just do the next one and the next one. So again, deciding to balance bill language requirements, 15 languages. Again, I found that website. I'm happy to share. This is very interesting, state by state, what those 15 languages are. And then, if you on a slide prior, don't go back. On the consent and what is it? The consent and notification and consent. And AB 72, it says 24 hours in advance. Now under the federal, you have three options: 72 hours. If it's scheduled, you have to do the notice and consent at least 72 hours. And I think that's why the date on that form and the date of service on your bill is where they're going to tick and tie to see if you complied with the notice and consent. And then if it's 24 to 72, same day, and then less than 24 hours, at least 3 hours before. And this was so interesting yesterday on that call with CMS, and I think it was a gal from Stanford. She asked the question, were you on the call? Yeah, with that urgent care question where she said, so patient walks in, right, the urgent care, and everything lines up and they're part of this no surprise bill. So to treat them, I need to give them this consent. So what are you going to say? Okay, Geraldine, here, I'm going to give you this consent. Go ahead and sign it. And I clicked my watch. So 3 hours, then we can call you back. And CMS was like, right? And they said, well, just send that question to the web page or whatever. Yeah. So, good, but a good question, right? I mean, because if I'm going to get consent and you've got these parameters in there, because the consent and form is not just the date of serve, but it's the time that you had the patient sign it. And what is on the UBO4, right? The admit date and the admit time, right? So I think that's where it's going to get tick and tied. Okay. Next slide. So again, and what's not part of AB 72 is also this disclosure stuff. And I think this is where the temperature from the patients is going to go through the roof. So one, I'm going to have to put it on my webpage. So dedicate a whole page on my website to no surprise billing. Then I got to display it prominently just like we do all your notice of availability of charity, in all of these particular areas, right? But not only that, then I have to give the patient this one-page plain language notice of no surprise bills. So, I mean, if you're a patient, then you're thinking, and if not, there wasn't so much controversy on the billing as it is right now. And now we're going to go through this. And then this is where, if you look at the model disclosure, you're like, from CMS, and it's like, you are not supposed to pay more. You have the right to do all of this stuff. And it's like, man, if I was a patient, I'd be like, oh, I was scared of the bill before I walked in here. I'm scared of the bill now for sure, right? So what we did was, next slide, when you look at the instructions for the model disclosure, it actually says in there that CMS some model language for its disclosure notice that is consistent with that section. HHS will consider a provider or facility that makes good faith use of that state-developed model language to be compliant. Well, guess what? On the the Department of Managed Care, they've got a one-page kind of really patient-friendly disclosure about what their rights are as a patient. So that's what we're using. And I think the only thing that we have to add to that now is the new CMS website that they just put up, cms.gov/surprises. I think that's what it is. So I think we just add that, and I think we'll be good. But this model notice from the Department of Managed Care really, really, I think, takes the temperature down as far as the language. So we're going to go with this. And then again, for surprise billing, so for the patient, in what if I get a surprise bill, out there on the Department of Managed Care, it gives them instructions. Do a grievance with your insurance company. They should be on the hook to get that corrected for you within 30 days. If they don't, get it corrected in 30 days. Here's a phone number, and here's a website for you to submit a complaint against that insurance company. So that's going to satisfy the one requirement from the feds about telling the patient, if they get a bill, what to do as next steps. And then the thing that's, I think, the big gap is the whole self-pay. The uninsured and the self-pay and the good faith estimate as part of this. And that was the no surprise bill, the part 2 part, the IDR and the good faith. So the interim final rule, and that's part 2, is requiring healthcare providers and healthcare facilities to provide good faith estimate of total expected charges to the individuals who are not basically enrolled in health coverage. It doesn't apply to Medicare, doesn't apply to Medi-Cal, workers' comp, TPL, all of those things. The convening provider, which is the provider that's going to perform the service, is the one that's on the hook. So if, in other words, convening equals hospital. So we're kind of on the hook if it's going to be performed at our hospital. And what they're giving us kind of leniency on is that, they're asking us to coordinate with the anesthesiologist, the co-surgeon, and all the providers that are going to be part of that care, go gather up all their estimates and put it in our estimate. So they're going to give us a little break on that, because I think they realize that that's a big ask. And then, but what they do say in here is, if the patients complain about those estimates, we're not on the hook for them. They have to defend their own. And then information regarding the availability of a good faith estimate must be prominently displayed on the convening provider's website and in the office. And then there's that one-page disclosure. So now we've got, here's the availability of charity, here's the no surprise, and here's the good faith. So patients walking into places, they're going to be so confused. And then they're going to get these one-page disclosures that are saying, hey, if they do this to you, this is what you should be doing, right? And I think it's just going to be, customer service is going to be, not the place to be, right? Next one. Estimates should be your cap rate. So with your uninsured discount, uninsured self-pay patients can initiate the provider or the patient provider dispute resolution if that estimate is greater than $400 wrong. Yeah. I'm going to drop the mic. Okay. Really? Do you know, let's see, customer service, we need to hire about, luckily enough for us, our self-pay population is not, all that big, but it's big enough for this to be worrisome. How do we get ahead of that? How do we get in front of that? Can we stop all our claims and check it against the estimate before it goes out? Probably not. I'm not really going to hire an army for that, right? How accurate are our estimates? I don't know. So I think we've got some work to do to decide kind of what's the best thing for not only the patient, but for us. And what the patient doesn't know is in this patient provider dispute resolution, because it goes through the federal part of it, we, the provider, we're able, if something happens during that surgery, you get a complicated, your bill is more than $400 more because you were in the OR for 2 hours because, something happened or something. What the patient doesn't know is, when we go to these things, that we're able to bring that information. And if it's deemed that, the stuff that we provided is medically necessary, then they call it something else, SD something, but I can't remember right now what that stands for. But it's not the independent thing. It's a whole separate thing. It's like a selected negotiator person. But if the patient could still be on the hook for paying that. But in order to get into this process, they got to pay. It's $25. But if the patient's looking at a bill more than $400, you bet they're going to pay $25 if they think that they can get that, don't have to pay that bill. But in all likelihood, they're probably going to be on the hook for something because hospitals just don't do stuff that's not medically necessary. So I think it's a misnomer to a certain extent. So what we've decided to do at San Diego is at the very minimum, we've redone, we are not using the model one page, you're entitled to go this route. We're using the language, but under that we're saying, gosh, if please call customer service, here's the number, here's how you can contact us, let us try to help you before we start going through this process. For us, we can take the information about, what happened with that estimate, kind of keep tweaking it. And I think the process of doing that and, maybe adjusting a few things here and there is going to be less expensive than defending a bill that's more than $400, probably almost every time, we turn around. So there's some, operational kind of decisions to make as to how to handle this going forward. And again, this again is going to be on our website and displayed prominently and given to the patient. I know we're an Epic shop, so some of these disclosures, so not to overburden the patient with so much paper. Again, in Epic, we can mark that we've given it to them and then expire that requirement after a period of time and then give it to them again. So some of this stuff we're going to handle like we do, like our conditions of treatment on outpatient. We only have it signed like once a year, and then it expires and then they have to sign it again. So we're going to try to handle it that way. And then we're looking at financial classes and guarantor account types to exclude, because again, it's only for those patients that are non-contracting provider in a contracting facility. So we're actually in our in Epic, it's called a DEP. It's like all our departments, and it's marked in there whether they are a place of service 11, an office, or a place of service 22. And I think we can actually get it down to that level. So we're really only giving the information to the people that we're supposed to be giving the information to. These are just the model things. Please go ahead. And then I just wanted to real quickly just call out AB 532, because again, I think this is an overlap with the good faith estimate. Under this assembly bill, we have to give the patient, it used to be upon request, the addendum that I think was signed early August or October by the governor. Now changes that, and it's for a person. So that means every time that they come in, we need to give them a estimate if they are uninsured, and then go on. It further, Section 2, this is going to impact your plain language summary for your charity, where you're going to have to add the address for the Health Consumer Alliance, the Covered California Medi-Cal presumptive eligibility, as well as the website for your shoppable services. So there's some updates in those forms to do, and that's kind of the same thing over again. No questions, right?
Well, you build a tunnel, so.
Okay, I guess. Okay, we'll defer that to the panel. So we are going to go in a 15-minute break. Please see you back at 3 o'clock while the panel gets ready for all of your good questions. Oh, 5-minute break. Okay.